syndrome. And what I want to do in this presentation is to show you that the early recognition is the key. We know that there are many things that can happen during patients who have floppy iris, and there is an increased potential for problems during cataract surgery. But most strongly associated with tamsulosin and So what we are looking at is the iris prolapse to the incision and a progressive intraoperative meiosis. And all these things are very important to pick up at an early stage till you progress in the surgery, and then you are seeing more and more problems, more and more prolapse, more and more intraoperative, the pupil getting smaller and smaller. So early recognition is perhaps the most important thing. And amongst that, perhaps preoperatively, a good history and assessment of the pupillary dilatation and looking at other risk factors is also important. So now we're looking here at the early, we just put in the trap in blue, and you can see as I'm trying to wash that off, there is a little bit of billowing of the iris. And synergy between topical atropine, prior to surgery, and unpreserved epinephrine and lidocaine do very well here. Perhaps important to point out here that this small amount of billowing is not of much concern to the surgeon because this pupil seems to be a good size. Only if the pupil size becomes smaller is then there an issue of doing a safe surgery. You can see here, you have to be very careful that whenever you're doing rhexis or whatever maneuver you're doing inside the eye, you don't touch the iris, because these irises are what we call idiosyncratic. They will behave in a very different way, and this pupil will come down very quickly. Hydro procedure is a step to master. And I want to emphasize here that if the fluid is going into the bag and creating a fluid wave, and then you have achieved a hydro procedure. But if it goes between the capsule and the iris, then there's going to be very severe prolapse of the iris and a lot of floppiness in the pupil coming down. As the pupil size keeps coming down, the surgeon's skills are tested. And you can see here, the pupil is coming down. I would want to stay away from the pupillary margin because this is very, very risky. But while you're phacoemulsifying, you also have a wide bore of the phaco needle. So you don't want the iris. As soon as we have come out, you can see the iris, not that floppy, came out a little bit, but we knew where it was. And as the pupillary size was going down, we have to look for any cortical matter so that we are able to do a good cortical cleanup. And you can see every time I go near the iris, even near the iris is coming out through the wound. Sometimes you just need to stay down, stay put, and the iris might fall back. Otherwise, I found this very important way of repositing the iris, a good viscoelastic. The plane has to be very good. If it goes behind, it's going to worsen the floppiness of the iris. And if it is going over the iris, then it's pressing it down, and perhaps the iris has less tendency to come out. Again, this is a very important step. You can see I have actually, in spite of the floppiness, increased the size a little bit so that I'm able to inject over the iris so that the iris does not get traumatized during the IOL insertion, which is a possibility with this problem. And at the end, another point at which the iris can come out again and again is when we are trying to stromal hydrate and close the wound, because at that time also it can come out again and again. You have to be very careful, it has to be gentle. And one of the good ways of handling that is that you are in the planes of the stroma, and you're not trying to actually inflate the AC also at that time. You can see here, even if I have stromal hydrated first, I've stopped the irrigation, came out, this time the iris did not come out. Again, very careful and gentle. I told you earlier that we have to avoid fluid and viscoelastic getting to the posterior surface of the iris. Here you can see, as soon as I'm trying to take out that capsule, the rhexis, which I've done, I was trying to routinely, like we usually do, remove it like this. But since the anterior chamber has overinflated, you can see the iris was coming out. Again, a viscoelastic to just push the iris down. If we do not deflate first and then push it into a certain direction, then it's going to worsen the floppiness. Again, here, I could already sense that this iris is going to be floppy. And as soon as I try to inject some here, you can see it's even gone behind the iris. That means that there's a lot of floppiness. Anyway, this is one tip I would want to share with everybody, that you turn off the irrigation to reduce the intraocular pressure before removing the phakic from the eye. So this has minimum risk of, again, after I'm stopping the irrigation first and then coming out. After viscoelastic cleaning, I'm turning it off first and then coming out. Another important step perhaps is where you are expecting is that you make an anterior and square thumb, and that reduces the chance of iris coming out easily. So once you've done that, you're already geared up and mentally ready for a floppy iris. And you can see here again, I'm trying to stain the capsule. You can see the iris billowing and the floppiness, quite floppy iris. So now in my mind, I have to think that things might get a little bad because the pupil here is already not that much. So I've used phenocane to try and dilate the pupil. Phenocane doesn't only dilate the pupil, it also gives some amount of rigidity to the iris so that it doesn't come down and becomes perhaps a little less floppy. The pupil keeps on going down even if you don't touch anything. You can see here, I'm trying to do a hydro procedure, and during the hydro procedure, very gentle hydro procedure, you can see the iris has a tendency to come out. And every time I go in and go out, there is this continuous tendency for the pupil to go down. So recognition is useless if the approach is not changed. You see, I kept on moving ahead, and you can see, I'll repeat this for you. You can see, even though I was not near the iris because this is so floppy, it has actually come and come into the. Now, when something like this happens, the iris will become floppier and floppier. Iris chaffing is a real possibility, not much of sphincter loss here, but this is the time to change strategy. So if I am using iris retractors now, and so that there's enough tension on the iris stroma, that so that there's no prolapse and the pupil becomes big, this I should have recognized early and fixed it at that time. And if I'd used iris hooks at that time, most probably I would not have caused this little injury. Little injury means injury to the iris, and that is always going to stay there. And it's not only painful for me to see, it's also painful for anybody, if anybody else is seeing it. And the patient can also have a little issue. So sometimes while we are keeping the iris retractors there, all the iris retractors before IOL insertion, there may be a little issue with the iris getting stuck, and sometimes we cause, so we remove one of the hooks before the IOL insertion so that it becomes easier and the iris falls down a little bit before we insert the IOL and remove the hooks. Again, this step very important, slow, gentle. You don't want the iris to be coming out again and again, and then repositing it again and again. You do a gentle stromal. You can see how floppy this iris is, and I should have recognized it the first time I saw this patient, smaller pupil, a little billowing of the iris. That would not have, that would have saved me from this small area here, which of the iris, which caused a little trauma too. The side port construction is perhaps an area where we would like to revisit. The wound and the instrument mismatch. You can see here the iris was coming out from the side port. This is the best way of repositing the iris if it has come out. And then if you are in a situation where you can be not using the second instrument, it's good here. I was able to, because I just had a little particle cleanup to do. And you can see that I was able to clean it up without the second instrument going in. So thank you very much for your kind attention.